Assalamu alaikum wa rahmatullah. Good evening. Uh, Thank you very much for joining us today, Friday day. So I think we are going to have a very interesting topics tonight to discuss. And this is really one of the most wonderful program where it really tackles few issues. And one of those main issues that we are facing on our daily practice, either as a management or as managing their consequences, is really hypertension. And here, in behalf of survey, I would like to welcome all audience, all the attendants, and hopefully in the coming 2 hours, we are going to have a very interesting topics to share and always to discuss. In this, I would give you just a brief in maybe 1 or 2 minutes, a very brief about this scientific comprehensive program, which really talks about fact checking about the renin, angiotensin, aldosterone system. So this is a fact-checking program, and this is a very comprehensive review of those scientific evidence which is behind the RAAS class molecules. With original approach, as always, it is addressing one of those beliefs. So sometimes we have a belief whether this is a true or a false regarding the RAAS, and we are trying to find out the truth, and this is based on evidence. So the scientific evidence is always there. So with this, we wanted to check this fact. It has got many chapters. In this tonight, we are going to have 3 of those scientific chapters where we are going to tackle different points. So in this, we're talking about weighing the evidence in hypertension management. And for this, we are bringing 2 eminent experts and speakers whom they are going to tackle this. And the second one is really talking about the RAAS in a very special populations, which is those who has individuals with myocardial infarction. And the other special population is those with diabetes. So in this, I have the pleasure really to introduce the first experts with us tonight, who's joining us from Italy, from Bologna. He's a Professor Claudio Borgi, who's a full professor of medicine and a head of Department of Medicine and the European Society of Hypertension Excellence Centers for Hypertension and Atherosclerosis at the University of Bologna. Again, Professor Borgi is well known in the field of hypertension, and he had chaired the scientific committee for the hypertension and the chairman of the research and science and educational committee of the International Society of Hypertension, as well as a member of the Council of the European Society of Hypertension. He was the past president of the Italian Society of Hypertension, where I think he would be the right person, where we are going to hear from him weighing evidence in hypertension. Now, the second chapter is really going to be tackled, where we would hear the expert, Dr. Musa Akbar, who's joining us from Kuwait. He's a well-known as an interventional cardiologist, where he works as a consultant interventional cardiologist, the head of cardiology unit at the Sabah Hospital in Kuwait, where he's very well known in the field of cardiology as a researcher as well as a clinician. And tonight we are going to hear from him what we are going to do with those special population and where is the RAAS class comes in those populations. And then the third topic is going to be, unfortunately, you're going to hear from me, which is me, Saud Sifri, an endocrinologist from Al-Hada Armed Forces Libya. So I would like to encourage all colleagues to participate in this by asking your questions, your comments in the chat box. Keep it there. We're going to take it. We have got plenty of time for discussion, at the end of the session. So without further delay, I would give the mic and the stage for Professor Claudio Borgi, where he's going to talk about weighing evidence on hypertension. So please, Claudio.
Thank you very much, Professor Al-Sifri. Could you see my presentation?
It's very nice, clear.
That's great.
I'm very proud.
And thank you for the invitation. It's a great pleasure and a great honor for me to be here tonight. And I see from my screen that a lot of friends, a lot of colleagues are connected with our webinar. So I think it's a great honor again. And my presentation will be something that will be extrapolated from the RAAS fact-checking program and talking about the evidence we have that hypertension should be treated and which one should be the logical approach to such important disease that is largely represented across the world. First point, of course, the role of hypertension. Hypertension is probably the most important risk factor for cardiovascular disease. We have many evidence that suggests that its prevalence is more than 50% on average, but in my country is more than 50% of the population, and the prevalence is going to increase across the world. Actually, hypertension is associated with many additional risk factors in over 80% of the patients, and it's a comorbid condition in many of the, let's say, heart diagnoses. Patients with atrial fibrillation, heart failure, have a history of hypertension beyond. But the most important point, I think, is the fact that hypertension is the first cause of death across the world, more than 10 million of deaths every year, and is responsible for the large proportion of myocardial infarction and stroke. So something that should be taken into account, that should be treated effectively if we would like to reduce the risk of cardiovascular disease and increase the protection of the people in the world. What we have to do to effectively treat blood pressure, first of all, we have to identify the patient with hypertension, which is, of course, pretty simple, but sometimes is not so effective in the general population. And basically, the level of blood pressure for the definition of hypertension is well defined by the guidelines, in this case, the European guidelines that suggest that is hypertensive every person who has a systolic and diastolic blood pressure above 140 and 90 millimeters of mercury. Of course, the level of normal blood pressure is different if you measure blood pressure according to ABPM or as a home blood pressure, the level of normal blood pressure value is a little bit lower. This is, I think, very important. We have to decide which one are the patient with hypertension. But if you would like to interpret the blood pressure value in the right way, I think we should try to follow the exact procedure. And in particular, blood pressure should be measured in a quiet environment. We should do at least 3 consecutive measurements and to do the average of the last 2 to define which one is the right blood pressure of our patient. Actually, among the possible warning, is very important to use the adequate cuff, because I think, at least in my country, sometimes this doesn't happen. And based on the blood pressure values we are going to measure in this way, we can decide which one should be the time schedule of blood pressure measurement in the population for the definition of hypertension. Is the blood pressure is very good, we can try to measure blood pressure once in a year for many years. If the blood pressure is close, the level of hypertension, it should be measured at least once every year. If the blood pressure is in the hypertensive range, of course, we have to try to be sure that this patient has a stable increase in the blood pressure values by using the home blood pressure and the ABPM. And in particular, the ABPM is very important if we would like to diagnose 2 different entities, which has been clearly emphasized by many of the guidelines, which is the white coat hypertension, blood pressure high in the office and normal outside, or the masked hypertension, even more important, normal blood pressure in the office, high blood pressure outside, which is associated with a huge increase in the rate of cardiovascular complications. So we have to define, we have to measure blood pressure in the right way. The second point is, as soon as we have the evidence that we have an hypertensive patient ahead of us, what we have to do, which one is the goal of blood pressure lowering? The goal, of course, is to reduce blood pressure, which is the most important, but in particular, the main goal of the blood pressure lowering treatment is to prevent the rate of major cardiovascular disease. And this is pretty clear. We are able to do. If you reduce blood pressure, we are at the same time able to reduce the incidence of the major cardiovascular disease in terms of overall cardiovascular events or the rate of coronary artery disease, stroke, heart failure, and all-cause mortality. So there is no way that the first thing we have to do to prevent cardiovascular disease is to improve the blood pressure control. And in particular, we don't have just to reduce the blood pressure values, but we have to achieve the target of blood pressure, which has been clearly defined by almost all the guidelines, and in particular by European guidelines that suggest that in any single class of patient, blood pressure should be reduced below 130/80 in the younger population and below 140/90 in terms of systolic blood pressure in the elderly population, with the same range of diastolic blood pressure below 80 millimeters of mercury. This is true also for the newest guidelines, the most recent guidelines, which are the guidelines of the International Society of Hypertension, pretty much devoted to the management of hypertension across the world, not only in some specific countries. And even the most recent guidelines clearly suggest that the target of blood pressure treatment would be the same, exactly the same that we have found in the European and the American guidelines. So there is no doubt that the treatment target is probably one of the most important features if you would like to prevent the cardiovascular complication, not simply reducing blood pressure. What about the drug treatment? We have to decide which one would be the best drug we would like to use for the management of hypertension. And from this point of view, of course, again, the guidelines are supporting some classes of antihypertensive drug, again, based on evidence. The European guidelines, again, are pretty clear, and they clearly suggest that we have probably 5 classes of first-line drugs, including drug inhibiting the renin-angiotensin system, ACE inhibitors and ARBs, calcium channel blockers, and the diuretics. These classes of drug can be used in almost all the classes or types of subpopulation of hypertensive patients. As far as the beta blockers, again, they are considered by the European guideline among the first-class drugs, but they should be used only in those patients for whom there is a specific indication for the treatment with the beta blockers. But actually, we have 5 classes of antihypertensive or first-line antihypertensive drug. But I think the most interesting finding is that when we talk about drug inhibiting the renin-angiotensin system, I just mentioned that we have 2 opportunities. And these 2 opportunities are not exactly alike. They are pretty different. In particular, ACE inhibitors should be considered pretty much different from angiotensin II receptor inhibitors. In particular, because of their mechanism of action, which is very different. The ACE inhibitors are inhibiting the angiotensin converting enzyme, so preventing the production of angiotensin II and increasing at the same time the plasma level of bradykinin, while the angiotensin II receptor blockers are blocking directly the angiotensin II receptor. So the mechanism of action is pretty much different, and probably the mechanism of action of ACE inhibitors is more adequate to interact with the pathophysiology of the hypertensive disease. In particular, these 2 classes of drug are not exactly the same in terms of prevention of the major cardiovascular events, and in particular, in terms of reduction of mortality. From this point of view, we have several meta-analyses that have tried to compare ACE inhibitors and ARBs in terms of overall and cardiovascular mortality. And you would see that all these meta-analyses are going in the same direction, showing a supremacy of ACE inhibitors over RBs in terms of prevention of mortality in the many different subpopulation of patients with hypertension, whether or not hypertension is complicated by diabetes, coronary artery disease, post-MI, or a general condition of high cardiovascular risk. And this is also true for one of these meta-analyses, which is peculiar, because in these cases, the authors have excluded the patient with heart failure, but considering mainly the patient with hypertension and diabetes. And even in this case, you would see the treatment with ACE inhibitor was associated with a less relative risk and less incidence of myocardial infarction, new onset of heart failure, and all cause of death. So again, another set of data that's supporting the superiority of ACE inhibitors versus RBs in terms of cardiovascular prevention. This is also true if you compare these two classes of drugs in terms of major cardiovascular complications. ACE inhibitor seems to be more effective for all the major cardiovascular complications in reducing the rate of the major CV complication you can see in the hypertensive population, but in particular, a lot of difference exists in terms of prevention of myocardial infarction. The rate of myocardial infarction in this large paper is reduced by ACE inhibitors, is significantly increased in patients treated with RBs, and this is probably due to the huge level of angiotensin 2 that you can see in the background when you are going to treat your patient with angiotensin 2 receptor inhibitors. So that's another demonstration that we are not talking of the same classes of drug. We are not talking about similar molecules, but two different classes of blood pressure lowering drugs. One of the most interesting findings that you can get if you look at the complex scenario of the treatment of hypertension with ACE inhibitors is the observation that most of the benefit that has been demonstrated for ACE inhibitors as a class can be achieved by trial using perindopril in comparison with all the other ACE inhibitors. So it seems that most of the favorable evidence we have in terms of prevention of cardiovascular disease with ACE inhibitors is focused on a single ACE inhibitor, which is perindopril. Actually, do you have any reliable evidence that support that perindopril can be more effective than the drug of the same class? Probably yes. If you look at the pharmacological profile of perindopril, you could see that it has a more extensive and persistent blockade of angiotensin converting enzyme when compared to the other ACE inhibitor, and at the same time, perindopril has a larger affinity for the binding to the tissue angiotensin converting enzyme that you certainly know is very important in the prevention of cardiovascular disease. The circulating ACE is about 20%, and the tissue ACE is about 80%. It is more responsible for cardiovascular disease. And this stronger interaction with the target, with the angiotensin converting enzyme, is responsible in terms of perindopril for a more effective control of blood pressure over 24 hours with a single administration of the drug, is responsible for the remarkable protection in target organ damage at the heart level, at kidney level, at the brain level, is responsible for the extensive improvement in endothelium-dependent vasodilatation that has been reported with perindopril in many different subpopulations of patients. It is also involved in the metabolic neutrality that you can observe when you are treating your patient with these particular drugs. So now we have defined which one could be the classes of drug that we can use and which one are the differences between the different ACE inhibitors within the same class of ACE inhibitor. Now, the next dilemma is how we should treat our patient with a single drug or with a combination of an antihypertensive drug. I think the answer is mainly in this very nice paper. I'm sure that everybody of you knows very well, but I think it's a pretty nice demonstration on what we should do. It's a trial, very simple studies based on a meta-analysis of a huge amount of patients in which the authors have compared the benefit in terms of the further blood pressure decrease in patient poor responders that can be achieved by doubling the dose of a monotherapy or by adding a second drug. And you can see from the white bar that the addition of a second drug to monotherapy is definitely more effective in terms of further reduction of blood pressure when compared to the doubling of the monotherapy. And this is the reason why all the different guidelines across the world are recommending the use of drug combination, and almost all of them are also recommending the use of drug combination as a first-line strategy in patient with hypertension. So not only we have to treat our patient with combination of drugs, but probably it could be reasonable to start the treatment with a combination in hypertensive patient to achieve a better blood pressure control. This is, I think, is very important. This is also in agreement with this nice paper published by Giuseppe Mancia a couple of years ago, and showing that the probability of achieving a satisfactory blood pressure control is much better with combination treatment, even much better with a single pill combination treatment when you put more drugs in the same pill. And this is a very important additional achievement. Not only combination treatment, but also single pill combination treatment could be very effective. And from this point of view, I think we have the evidence on why the single pill combination treatment should be more effective from this paper, nice paper published from Australian colleagues, and showing that shifting from free dose combination to single pill fixed dose combination of perindopril and amlodipine, you can achieve a significant improvement in the adherence to the antihypertensive treatment. And this improvement in adherence translates in improvement in survival, in lesser mortality. So again, less pills means best adherence, and the stronger adherence is translated into an improvement in the clinical outcome. So I think that we have enough information to support the use of combination treatment in patients with hypertension. But if we endorse the combination treatment as I think the most important strategy, or probably the most reliable strategy, the next step is what kind of combination, which drugs should be more effectively combined among the first classes of drug for the treatment of hypertension. From this point of view, I think, again, the guidelines are suggesting what we should do. Again, these are the guidelines from the European Society of Hypertension that are clearly suggesting that when you combine antihypertensive drugs, and the combination is suggested as an important first-line strategy, you should try to combine the drug inhibiting the renin-angiotensin system with a calcium channel blocker and the diuretic. And if you are not achieving a satisfactory blood pressure control, you should use 3 of them, all these 3 drugs in the same patient. This is, I think, a very important concept, in particular, the importance of having a drug inhibiting the renin-angiotensin system on board. As I tried to demonstrate just previously, among the drug inhibiting the renin-angiotensin system, the ACE inhibitor seems to be stronger in terms of prevention. So probably the combination of an ACE inhibitor and the calcium channel blocker, or an ACE inhibitor and the diuretic, seems to be definitely the best solution for the management of hypertension. What about the newest guidelines? The guidelines of the International Society of Hypertension. They are moving exactly in the same direction, and they suggested in the optimal situation, a combination of a drug inhibiting the renin-angiotensin system and the calcium channel blocker should be the best. I think this is supported by the evidence of the accomplished trial and the many other data we have from the many trials going exactly in the same direction. And again, even the ISH guidelines suggested that triple therapy should be the next step in patients with who don't achieve the blood pressure control with 2 drugs. In these guidelines, there are 2, I think, news if you compare this document with the European or the American guideline. First of all, the first line should be drug inhibiting a renin-angiotensin system, I would say ACE inhibitors and the calcium channel blocker. And the second point, if you decide to use a diuretic, it should be a thiazide-like diuretic. Now, I think since we are talking about evidence, the point is, show me the evidence. Why this, let's say, different choice to address the treatment toward the combination of an ACE inhibitors and the calcium channel blocker and the specific class of diuretics. But we have of course, the evidence. There are no guidelines based on nothing. All the guidelines are based on the evidence, on the available evidence. First of all, the evidence comes out from the analysis of the many randomized trials comparing different combinations of antihypertensive drugs. These are data that are extrapolated from a table that you can find in the European guidelines. You would see that if you look at the results of the randomized clinical trial testing the different combination of patients, you can have over 75% of positive trial with a combination of ACE inhibitors and the calcium channel blocker, about 70% for ACE inhibitors and the diuretic, about 50%, something lesser for the RBs and the diuretic, while we don't have any trial testing RBs and the calcium channel blocker. We don't have any evidence that this kind of combination is effective in preventing the major cardiovascular disease and in reducing mortality. Another important evidence is coming out from the analysis of the different trials that are supporting the first-line combination in the treatment of hypertension. And you would see that most of them, I would say 90% of them, are based on a combination of ACE inhibitor plus a calcium channel blocker on a diuretic, while we have just one trial supporting some, let's say, better successful control of blood pressure and clinical outcome with an RBs, in which the losartan has been compared with atenolol, but in a very peculiar population of patients with left ventricular hypertrophy. And in particular, if you look again at all the trials suggesting and supporting the role of ACE inhibitor, you would see again that most of them have been done with one single ACE inhibitor, perindopril. So it means that not only what the ISH guidelines say is true and is supported by the evidence, but it's also true that most of the successful trials supporting such evidence are those carried out with perindopril. I've already mentioned to you which are the reason why this ACE inhibitor can be so effective, particularly in combination with other drugs. And in particular, a third point, which is, I think, very interesting, is very interesting to me that I'm working since many years on the interaction between the different risk factors. We have also evidence that the combination of an ACE inhibitors and the calcium channel blocker will be the ideal combination in patients with hyperlipidemia. And you know very well how many patients with hypertension have hypercholesterolemia. In this population of patients, if you combine an ACE inhibitors and the calcium channel blocker with the statin, you get some huge advantage in terms of reduction of myocardial infarction, in terms of reduction of stroke, which is not exactly the same when you combine the statins with the beta blocker and the diuretic. And the rate, the extent of the benefit is definitely reduced, even whether these two combinations in this trial, in the ASCO trial, were absolutely comparable in terms of blood pressure control. So it means that there is something beyond the blood pressure control. There is something that supports that the triple combination of a statin, an ACE inhibitors, and the calcium channel blocker would be able to interact in the best way with the progression of the atherosclerotic disease. What about the definition of the diuretic? If you remember, the ISH guidelines suggest that the thiazide-like diuretic should be the best in terms of the thiazide type instead of hydrochlorothiazide. And the same information can be found in the NICE guidelines. Is this again supported by evidence? Absolutely yes. This is a meta-analysis comparing the different oral diuretic we are going to use in the treatment of hypertension, and you would see like the thiazide-like diuretic, clorthalidone and indapamide, are definitely more effective than hydrochlorothiazide in terms of blood pressure control. And if you move to the tolerability profile, which is very important, in particular because of metabolic neutrality, you would see even some differences between the two thiazide-like diuretics, clorthalidone and indapamide, with indapamide, which is responsible for the lesser incidence of hypokalemia, but in particular, the indapamide is associated with a lower rate of hyperuricemia And you know very well, I tried to dedicate most of my life in the last 5 years to this problem, that hyperuricemia means a significant increase in the rate of cardiovascular disease. So any drugs which is increasing the plasma level of uric acid can have some, let's say, negative impact in terms of prevention of cardiovascular disease. So it means that having on board a diuretic that is not causing any problem in terms of metabolic profile would be much better. And again, this is a clear demonstration that support what the ISH guideline are saying in terms of best treatment of hypertension. And what about if you would like to combine all these three drugs together? Do we have any evidence that the triple combination works in terms of blood pressure control? Absolutely, yes. There are 3 different trials. I'm just showing one of them, which is the larger in terms of number of patients involved, is the Pianist trial, and you would see that the triple combination of perindopril, amlodipine, and indapamide is able to provide a significant reduction of systolic blood pressure, regardless of the severity of the hypertensive disease and regardless of the baseline background treatment. Whatever is the treatment in your patient, in poor responder patients, single drug or a combination of 2 antihypertensive drugs, the triple combination is always associated with a significant improvement in terms of blood pressure control. And we have some strong evidence that support that this triple evidence is probably associated not only with an improvement in blood pressure control, but also with a significant improvement in the clinical outcome. And this comes out from the results of a sub-analysis of the advanced trial in which the population of patients treated with perindopril and indapamide plus a calcium channel blocker has been compared with a population not taking a calcium channel blocker. And you would see that the addition of a calcium channel blocker to the number of drugs used to treat these patients is associated with a better outcome, and in particular, a significant reduction in the overall mortality, which is pretty much in line with the evidence that have been supported by the many other trials and by the evidence of the meta-analysis supporting the primary role of ACE inhibitors in cardiovascular prevention. But there is another advantage that we can get by combining ACE inhibitor with other drugs in terms, and in particular calcium channel blockers, in terms of management of hypertension, is the possibility that this combination can reduce the rate of major cardiovascular events and major safety and adverse events. This is particularly true for the ankle edema. You know very well that ankle edema is a significantly increase in patients treated with dihydropyridine calcium channel blocker. And you would see from this meta-analysis that if you combine a dihydropyridine calcium channel blocker with an ACE inhibitor, what you get is a significant reduction in the concurrent incidence of ankle edema. So you can manage the most important side effect of a calcium channel blocker by adding an ACE inhibitor. The same is true for the other important ACE inhibitors that you can observe with antihypertensive drug and particular ACE inhibitor, which is cough. And even in this case, you would see the rate of cough can be significantly, that you can observe with ACE inhibitors, can be significantly reduced when you combine the ACE inhibitors with the calcium channel blocker. And again, there is a rationale, because the mechanism responsible for cough in this patient is calcium mediated. So if you block the entry of calcium, you can reduce, of course, the rate of cough. And the rate of cough can be reduced even more in patients treated with a triple combination of an ACE inhibitors, calcium channel blocker, and the diuretics in both men and women. So I think it's a very important point. Using the combination, and in particular this combination we have mentioned before, we can have an improvement in the blood pressure control and improvement in clinical outcome and the significant reduction in the rate of the major cardiovascular event. Very recently, these are my last 3 to 4 slides, the use of drug inhibiting the renin-angiotensin system has reached the stage as a possible treatment in terms of clinical outcome of patients with COVID-19. You know very well that the problem of COVID-19 across the world, I was just discussing before the starting of this meeting with my friends that in Italy, we are going to have a new lockdown for the Christmas time because of the number of infected people, which is going to increase. In this important population of patients, we have enough, let's say, evidence that of the renin-angiotensin system is working very well, because the virus is able to destroy the ACE2, and the destruction of the ACE2 reduces the production of this angiotensin 1,7, but at the same time increases at the tissue level the availability of angiotensin 2. So angiotensin 2 is absolutely the master of what happened at the level of the arterial wall, even in the lung, and is probably responsible for some vasoconstrictive and prothrombotic complication. In this particular situation, drugs blocking the production of angiotensin 2 seems to be very effective. At the beginning of the pandemic, someone suggests that the treatment with ACE inhibitors and probably with RBs was associated with a significant decrease in the risk of infection with COVID-19, just based on some kind of presumed overexpression of angiotensin 2, but this is not exactly true. A couple of nice and large studies have been supported different hypotheses, and I think the most important is the one published by Italian friends, and in particular by Giuseppe Mancia, showing that ACE inhibitors and RBs are not actually associated with a significant increase in the risk of COVID-19 infection. On the other side, after the destruction of these negative hypotheses, we have increased over time in the last 6 months the number of papers supporting the primary role of drug inhibiting the renin-angiotensin system in improving the clinical outcome in the population of patients with COVID-19. But this is true after the adjustment for the many confounding risk factors. And as you can see from the right side, is not absolutely dependent on a difference in the improvement on blood pressure control. This is a comparison between different antihypertensive drugs, and the improvement in the clinical outcome is not dependent on an improvement in the blood pressure control. So it's something which is intrinsically related to the mechanism of action of angiotensin 2, of a drug inhibiting the renin-angiotensin system, and I think is due to interaction with angiotensin 2. But in particular, studies like this have clearly demonstrated that the rate of death and major cardiovascular complication is pretty much reduced in those patients treated with ACE inhibitors at the time of admission to the hospital. This, I think, is very important. First of all, because it can be useful in the definition which one should be the treatment. And second, because it supports, again, that to be treated with drug inhibiting the renin-angiotensin system, and in particular with ACE inhibitor, can be in some way a protective mechanism if you are be infected with COVID-19 against the progression of the disease. And this is the reason why all the most important professional societies, including, of course, the European Society of Hypertension, the American Heart Association, the European Society of Cardiology, and many other societies across the world, I've clearly suggesting at the beginning of this pandemic that the treatment with drug inhibiting the renin-angiotensin system should not be stopped. At that time, it was just an hypothesis based on the, let's say, experimental data, not supporting the possibility that this drug can be dangerous. Now, we have the evidence that this drug can be even effective in terms of prevention of major complication of this very important and difficult situation. So finally, this is my last slide, and I hope to have respected the time that has been allowed to me. We can clearly conclude that arterial hypertension is the most relevant risk factor for cardiovascular disease. A correct diagnosis of hypertension is crucial for its adequate management. Hypertension should be treated to blood pressure target if you would like to prevent cardiovascular disease. And drug inhibiting the renin-angiotensin system, in particular ACE inhibitor, which are definitely superior, calcium channel blockers and diuretics, talking about diuretic of triazide-like types, are the first-line drugs. Combination treatment, in particular single pill combination, should be preferred in most patients to achieve the target of blood pressure control. And we can say that perindopril, amlodipine, and indapamide have been combined in many successful trials. Their dual or triple single pill combination is safe and effective in many patients with different risk profile. And finally, what we hope, what we expect for the future, the use of drug inhibiting the renin-angiotensin system might be beneficial in patients with COVID-19 disease. We all hope that this pandemic is going to stop with the use of vaccines. But in the case of the patient that have to be treated with some drugs during this situation, I think that is brand new about the possible role of blocking the renin-angiotensin system can be very useful and effective. So actually, I was delighted to be here with you. I would like to thank all of you for your kind attention, and I'll give you back the my presentation to Professor Al-Sifri.
Thank you very much, Professor Claudio. That was really very interesting. You were on time, and really you managed to do very well in the way that you showed us the evidence on hypertension and really what RAAS could be utilized and how we could get the maximum benefit of that. Now we would come to the second chapter. Again, I would encourage all colleagues who are watching us. Please, you have the Q&A box. So please post your questions, your comment. We're going to come back to that. We would like to hear from you any questions, any feedback, so that we would manage to answer it at the end. So again, I'm going to give the stage for my senior colleague, Dr. Musa Akbar, who's an interventional cardiologist at Kuwait, at Sabah Hospital, where he had been a very active member of different scientific societies, Kuwait, Gulf, as well as other international. He's a well-known in the field as a clinician as well as a researcher, and we would be very delighted to hear from him about the RAAS in special population, those with myocardial infarction. So please, Dr. Musa, you've got the stage for you.
Thank you very much, Mr. Chairman, for the nice introduction. Good evening, ladies and gentlemen. It's my great pleasure and honor to participate in this symposium and given to me a very good task, which is the role of the RAAS blockade in post-myocardial infarction. Before I start, I would like to thank Servier for asking me to participate, and I would like also to welcome all the participants in joining this symposium. So this is a very important topic, especially for those who are preparing for board exam, post-cardiology exam. And I also throw some questions for you to refresh your memory and to prepare if you are going to prepare for the post-cardiology exam, board exam. This is my disclosure as advisory board and speaker honoraria. I subdivided my talk into 4 subheadings with the 4 questions, each subheading with 1 question. So we will see the effects of ACE and ARBs on endothelial vascular function. This was highlighted by our guest from Italy, Dr. Claudio, but I will just emphasize more. And then we'll talk about the prevention of both MI and death. Is it both are similar with ACE or ARBs or any different? And then both early and late administration of ACE post-MI do show any mortality benefits. And finally, the ACE or ARBs, are they equivalent in terms of long-term benefit post-MI? So let's go to the first subheading, which is the effect of ACE or ARBs in endothelial and vascular question and vascular structures. This slide depicts the differences in the mechanisms highlighted by our first speaker, but I'll emphasize more again, because I have different to show the mechanism. The RBs block specifically AT1 by from the angiotensin receptor, so exposing more unopposed blocking by AT2 receptor, while the ACE block the angiotensin 2 formation from angiotensin 1. But what is important, so you will be blocked in the 2 receptor. But what is additional is this one, is the inhibition of degradation of bradykardin to the inactive fragment. So you have more enhancement of the bradykinin system through bradykinin 1 and 2 receptors. And these are the protective mechanism or beneficial mechanism for 2P through the nitric oxide and the endothelium-derived hyperpolarizing factors and prostaglandin, and all at the end have vasodilator effects and anti-fibrosis, anti-inflammatory, anti-reactive oxygen species, and anti-thrombosis. But the difference are explained more in this slides. The difference is mainly that in ARBs, when you block AT1 receptor, there is a reciprocal or an activity more by unblocked AT2 receptors. And this really has no effect on the bradykinin system. In fact, there is a degradation of bradykinin, and then there will be a less bradykinin, and that with the ARBs. In opposite to ACE inhibitors, where you will have the block of angiotensin 2, then you have an enhancement or increase in bradykinin, and then they will have the beneficial effect out of which is anti-apoptosis and increase in pro-growth. While here you have increase in pro-apoptosis and apoptosis. And therefore, the ARB had a blood pressure control, but because of this mechanism difference in apoptosis, then there is no effect on endothelial continuity and function. In other hands, the ACE has a good effect on endothelial continuity and function. And therefore, it is because of that they believe that the ACE is different from ARBs in sorts how through this mechanism of the cardioprotection. Now, what happens when you have acute MI? You will have a remodeling is started to occur because after acute MI, you have activation of the RAAS system and adrenergic nervous system. In the adrenergic nervous system, you will get a positive inotropism with increase in contractility and positive chronotropism on the heart rate and tachycardia. We know that the resting heart rate is a bad ominous sign because it's very well correlated into increase in sudden death and mortality and shown in many studies. So bad when you have a heart rate increase, so that the effect of this ultimately lead to left ventricular systolic dysfunction. But because of the prolonged adrenergic activation and through the muscle injury, the cardiac muscle injury, and the RAAS system through angiotensin 2 with a deleterious effect in the heart, you will have what is called the remodeling, the progressive progression of disease ending up with the remodeling. The remodeling is a very important as a remodeling occur because of the activation of angiotensin 2, and then there is increase in fibrosis, apoptosis, and I show you where the inhibition occur from bradycardium. With the aldosterone, you have sodium fluid retention, and with increase in the ventricular cavity, then increase in afterload. So the ACE is believed to reduce plasma angiotensin 2, so prevent all of the nasty or deleterious effects through the angiotensin on the heart, and also decrease the alveolar stress by reducing the afterload and fluid retention or the preload or reducing both. But what is important is this slide for those who are interested in getting the higher education exam and the postgraduate is what is the mechanism of inhibition of ACE in remodeling after MI. The heart is elliptical shape. When you subject to MI, and what happens over weeks to 1 year, the volume in diastolic, systolic volume are increased. So it turned from the elliptical shape into the spherical shape. And by the law of Laplace, which is stated here, the left ventricular wall stress is positively related to cavity pressure with the multiplied by radius divided by wall thickness. So the cavity pressure with radius are increased, and that will have an impact on left ventricular wall stress by increasing the wall stress. To reduce the wall stress, the heart has to thicken or hypertrophy. In MI, it is not possible, and ended up that the cavity increased and that the wall ventricular wall stress increased. It is believed that the ACE inhibitor reduces the left ventricular wall stress. But what is the most important is the mechanism of number first. There are 4 mechanisms. The first mechanism is the most important, is the attenuation of remodeling. And this is a critical, very important role of ACE playing an inhibitor after MI, the attenuation. The other mechanisms is the preservation of ischemic preconditioning, and then the reduction of recurrent MI and ischemia, reduction of sudden death. All of this plays a major role in what we will show you now of the trials of ACE that important in the reduction of mortality as well as in the reduction of MI. So the first question that I posit for you are ACE and ARBs, given what I have talking to you, they have a similar effects on the endothelial and vascular function. The answer is no, they are different, and I show you the difference in their mechanisms. So let's move to the second part, which is the prevention of both acute MI and death by ACE or ARBs or both, or any difference. Let's take quick glance on the RAAS clinical trial post-MI. Remember that the most randomized trial in RAAS blockade, they started as early within 24 hours, and it's called short-term, and I'll show you the trials, up to 2 weeks following acute MI. And the improvement that has been shown in ejection fraction was at 1 month and 1 year. And that improvement has reflected an improvement in survival at the 1 year. But keep in mind the limitation of old trial, because these are old, 92, 93, 94. These studies, majority of patients at that time were ST segment elevation MI. So we have a data limited in patient with non-ST segment elevation MI. And also we have at that time, the PCI was not the strategy of reperfusion. It came only late in early 2003. So the data who underwent PCI for MI also limited. And therefore, in most studies, the current PCI strategy that we are applying today was not used in many patients, and some of the patients are even not reperfused with the thrombolytics. Let's show you now the milestone in the history of the ACE post-myocardial infarction. At least 9 trials I have shown you: the consensus 2, 92, the SAVE, the AIR, GC3, ISIS-4, SMILE, SMILE-2, TRACE, and PRIME. And these you can see we have started as early 92 up to 96, and on of all, more than 92,000 patients. And those in ISIS-4 and GC3, SMILE, their studies specifically in acute MI, and the treatment in these trials has been initiated within 24 hours of symptoms. So let's take a look quickly on the first trial, the SAVE, 2,231. At that time, ejection fraction less than 40 were in the trial. but without over heart failure, were not enrolled in this. And then they initiated at 3 to 16 days after acute MI. And that reflected in long-term mortality. You can see up to 3-4 years. Captopril, of course, need doses in titration from 6.25 up to 53 times daily. And that showed a significant reduction by 19% in terms of mortality reduction with a significant p-value compared to the placebo. In 92, we are comparing a drug with the placebo. Now, in the SAFE, we want to see what are the causes of the death. Of course, the cardiovascular death was significantly reduced, as well as all mortalities, 19%. And out of cardiovascular death is atherosclerotic cardiovascular disease and the progressive heart failure from the ejection fraction of 40 are also significantly decreased at that time with the usage of captopril. And then the AIR trial comes a year later in 2003. In 2006 patient, they did one thing that was not done in the SAFE, which is patients with a clinical evidence of heart failure after MI were enrolled. Remember, in the SAFE was without over heart failure. This is with, and then they initiate treatment more or less 2 to 29 days and using in this time ramipril and not captopril. And it showed that after 30 months, there is a significant relative risk reduction of about 27% in terms of mortality reduced with the usage of ramipril over the placebo. But also they have seen another advantages, and that's ramipril significantly reduced the risk of sudden death by 30%, and that largely due to reduction of progressive heart failure, because those with ejection fraction less than 40 were enrolled in the trial. So there is also here a reduction of sudden death, and I showed you the mechanism of the attenuations of the remodeling and effect in left ventricular wall stress. Now, these are the short-term studies, the usage of short-term within 24 hours of usage, the GC3 and the ISIS-4. And these are again post-MI. In the GC uses lisinopril, and in the ISIS-4 using captopril, in the blue bar, in the ISIS and the green in GC. And you can see introduction of the drug within 24 that has reflect in the mortality first day, a significant reduction, 30% almost, and here 27% reduction of the mortality. So early administration of the drug reflected by early reduce or reduction of mortality. And these are short-term studies with the short-term outcome data. In the GC3, they did something more. They stratify in subgroup analysis later on to diabetic no and versus no diabetic. And it found that, of course, diabetic is the high-risk population, that the lisinopril in the diabetic exert more reduction in mortality compared to the placebo, no lisinopril, and the significant reduction in the relative risk reduction, if almost about 32% relative risk reduction. And remember, as I have said, treatment was initiated within 24 hours of symptoms onset after acute MI. Now the trace, so we have short, let's go to the long term. The long term or longest out of those trials is the trace using trandopropril up to 6 years. And it showed that the mortality curve is reduced as early and continue to diverge. And it was followed, if you followed at 6 years, you will find still you have life saved. And at the 6 year, the difference in median survival was 15.3 more months in favor of trandopropril over the placebo. And the treatment here started again, not 24 hours, but the 3 days to within 1 week after MI. So there is a short term, and this trial showed a long term as much as 6 years in this trial. Now the SMILE trial, they use another ACE, zofenopril, and the zofenopril was used in the SMILE trial in 2 terms. In the short, as much as 6 weeks, 6 weeks, 42 days, and as a 1 year. And it showed that as early, if you give a 6 weeks of the treatment, the zofenopril reduced the mortality by 34% relative risk reduction compared to the placebo. And that reduction is the composite, in fact, of the death or severe congestive heart failure after MI. The interesting things in this trial that some of them, they did not receive reperfusion strategy, i.e. they did not receive thrombolytics. And that's why they have a failure, and that's why they benefited most from the ACE inhibitor. So this is a short 6 weeks. When you extend it to 1 year, still the curve continue to diverge in favor of the drug treatments, the zofenopril over the placebo, and the risk reduction on the year was 29% relative risk reduction. So there is a clear benefit in early and late, especially following. The benefit was more noticeable in what? In acute anterior wall MI and in those who have heart failure or LV dysfunction at the presentation. The SMILE, they did one more thing, it's called SMILE 2. They want to see if their drug showing this remarkable effect on the short term and the long term, then shall we say that our drug is superior to lisinopril? So they did the objective SMILE 2, thrombolized patient, initiated zofenopril plus lisinopril, and they showed there is no superiority of zofenopril over lisinopril, so no differences in mortality at 6 weeks and no differences in any incidence of major cardiovascular complication safety between the 2 drugs. So no superiority of the drug over zofenopril over lisinopril, as no differences in mortality. The PREAMI trial showing that if you give perindopril, it has an impact in remodeling, and that showed after 1 year that giving perindopril in elderly showed that the remodeling is improved, as reflected by the adverse LV remodeling. Any more than 8 increase in left ventricular end diastolic volume was significantly reduced, and that is one part of remodeling. I show the 3 weeks and years how the volume increase and large heart, so this is reduces the volume and then attenuate the remodeling. So we have here a data that really the ACE inhibitor attenuate the remodeling after acute MI. Then we have asked ourselves a very important, are all ACE inhibitor exist the same benefit among them in terms of post-MI, in terms of sudden death, MI, mortality? And that's the question. So not known whether all have equivalent effect, but at least we have a meta-analysis of almost 6,000 patients in a 3 trial. The SAVE, we use captopril, the ramipril, and trastuzumab, and showed similar mortality reduction in those in meta-analysis. So most randomized trial show that the ACE in general improve left ventricular function following MI, but they are not, at least all of them are same effect. So you cannot say this is a class effect, and I will show you why in some later on in my subsequent slide. So this is the meta-analysis of the 3 trial. The SAVE, captopril, ramipril, and trastuzumab. Using these 3 medications showed that the ACE improves the outcome after MI with a significant reduction in mortality of about 25% relative risk reduction with a significant p-value. So these 3 drugs works in terms of reduction in mortality. Now, in terms of ARBs in post-MI, there were only two medications that has been, two trials, sorry, that has been studied post-MI, and that is the Optimal trial, which used losartan versus captopril, and the Valiant uses valsartan versus captopril versus both. And so that was the two trial in the ARBs. Let us have a look on them. In Optimal trial using losartan, you can see that the p-value is not significant. Sorry, it all causes mortality, no differences between losartan and captopril in terms of the mortality. The subgroup analysis, and you divide it for the primary endpoint mortality, you will find that all of them touch the unity and therefore no significant or favor of ARBs over captopril. If you see there is a trend toward the ACE over ARBs in majority, but again, they all touch the unity in difference of the pre-specified endpoints, and therefore consider this is a non-significant difference between the two drugs. When it comes to the Valiant trials to show the differences, and again, the Valiant showing no differences in endpoint between the captopril or valsartan or both in terms of the death of any causes or combined cardiovascular endpoints. And it showed that the drug has met the non-inferiority endpoint, that is as good as the captopril, but it didn't show any superiority of different endpoints. So the summary of Valiant in terms of cardiovascular mortality and morbidity, the valsartan was at least effective as captopril, as met all the non-inferiority criteria in reducing the risk of major cardiovascular event, but neither combination nor the valsartan showed any superiority over the captopril. And that leads us to the second question, ladies and gentlemen. With ACE, but no ARBs can prevent both MI and death, and I showed you the Optimal and Valiant versus all the others, and the fact that they show mortality versus in the ACE, but not in the ARBs. Let's move to the third. Both early and late administration of ACE, POSM-I provided mortality benefits. At times, very important, and I show you the different meta-analysis that we have two types. We have short-term trials of early administration within 40 hours of MI, significant reduction mortality at 1 month, and significant mortality reduction at 1 year. When it comes more than 48 hours after MI initiation, again, significant reduction in mortality in 1 year, and up to 3 years still you find significant. In other words, you can start ACE within 24-hour MI in stable patient, not a fragile, not in shock or a pre-shock or decompensated. In a very stable patient, you can start it as early as 24 hours. And you provide, these are very fragile in acute MI, so doses are important. Don't give the higher dose, but low and titrated according to the response of the blood pressure. Of course, the intravenous IC has not, ACE inhibitor not recommended because of risk of hypertension, shows not any positive trials. And the message here with all the trials that I've shown you, you treat all patients, especially of high risk after MI, with RAAS blockers indefinitely. So the question, both early and late administration of ACE POSM-I provided mortality benefit. The answer is yes, true. We have seen some trials given early showed benefit and some given late showed benefit. The benefit is as early as 1 month, then 1 year, up to 3 years. Let us move to the last component of my talk, and I will conclude that the ACE and ARBs are equivalent for long-term benefit post-MI. The major or the majority of data come from Korea, and that is called the CAMER registry. We have a registry data, they are not randomized, but the registry is telling what we are doing in daily practice. So the data is long-term survival benefits. These are patients from Korea registry data, more than 12,000 patients. Majority got reperfusion of PCI, 84, bypass, 94. They divided into ACE, ARBs, and no RAAS blockade, and clinical cardiovascular all causes mortality at 1 year. When you see the all cohort in the red is the ACE, this is survival probability, not mortality. And the black is no RAAS, and the blue is ARBs. You will find that survival was better with the ACE. When you make a the match, what do you call it, PS matched, propensity score matched, you will see that still the survival benefit is with the ACE compared to the ARBs or no ARBs. So when you take pre-specified, you will find that in the total cohort or propensity score match, all have persistent benefit with ACE inhibitor, whether STEMI patient or non-STEMI, whether low ejection or higher ejection, diabetic, no diabetic, or kidney impairment or no kidney. The benefit, according to the registry data of Korean, showing better in ACE than in ARBs after 1 year survival. Now they did one more test as they're from registry, is adding a beta blockers. Beta blockers has been added with ACE and beta blocker added with the ARBs, and taking a 2-year follow-up from their registry, again taking all STEMI patient, and the majority, if not, went unsuccessful PCI and testing the endpoint, and showed that after 2 years, the MACE in all patients was doing better. In lower MACE, the red is ACE with beta blockers versus ARBs beta blockers, favoring the MACE was much lower in the ACE with the beta blockers. When you match it with a propensity score match, avoiding the some of the variable and try to matching to avoid the error, you will find still the ACE with beta blockers is better than ACE with the ARBs. And not only that, it showed that the diabetes and multivessel disease, they benefited most from ACE and beta blockers over the ARBs beta blocker to reduce the MACE in a pre-specified endpoint. One more of which really the ACE is better, or the class effect, we have the data. It's a retrospective real world data in elderly patient more than 65. They took ramipril as the reference of their drug and giving within 30 days of discharge ACE inhibitor. There are at least 6 ACE inhibitors compared to ramipril as a reference, and it showed that the mortality and readmission differs. So lisinopril is no different from ramipril, perindopril is no different in ramipril in terms of mortality and readmission, while enalapril, fosinapril, and captopril and quinapril, they have a higher mortality at 1 year in that retrospective in elderly, and the two drugs, fosinapril and enalapril, have high readmission rate, readmission for congestive heart failure than the ramipril and perindopril. So in other words, in terms of the survival benefit, the ramipril, perindopril showing the better survival compared with the other ACE inhibitor. And the criticism, this is a retrospective real world data, and the baseline is different, and therefore, and then you can say that from this study at least that there is a drug effect and not a class effect of the ACE inhibitor. Last 2 slides, ladies and gentlemen, and Mr. Chairman, and I will conclude, and I apologize, I took a little bit beyond my time. There are 2 trials important. The Europa trial in 2003 did a study of using perindopril in a stable patient. There are 3 things: a stable patient, they are not high risk, and not overt heart failure. Giving them perindopril, and they have these history of MI 65, so more than 2/3 history of MI. And what it showed in those who have history of MI, there is a reduction of composite endpoint of giving perindopril in the stable low risk profile patient. And that risk reduction from the composite endpoint of cardiovascular death, MI, or resuscitated cardiac arrest was lower with perindopril versus the placebo of 22.4. So the drug works in the low risk profile. HOPE study is the opposite, taking very high risk group, no heart failure, and they are high risk for fatal cardiovascular event, giving them ramipril, and it showed in these populations, especially in diabetic, there is a significant reduction of MI by 20%, stroke and death from cardiovascular diseases. So giving them even without acute MI or without LV dysfunction, still ACE inhibitor showing a benefit, and that beyond the blood pressure control. Class difference of ARBs, we have no evidence. Guidance available, which is preferred as a case different combined. So we can say that until now we have no data, and it's not a class effect in terms of the ARBs. Final question, ladies and gentlemen, ACE and ARBs are equivalent according to the Korean registry data for long-term benefit. The answer is not. We have seen that the ACE either combined with the beta blockers alone showing a better in terms of survival benefits. So, Mr. Chairman and dear colleague, to conclude over my presentation of RAAS blockade acute MI, I showed you that the treatment with RAAS blockade should be started as early as possible, especially post-MI, and continue it indefinitely wherever the patient is stable, and the blood pressure must be monitored to avoid hypotension. Also, in none of the trial that showed that the combined therapy of ACE and ARBs are beneficial and should be avoided, especially from the on-target trial, where the combination of this showing a more incidence of hypotension, more hypokalemia, and more kidney deterioration and acute kidney injury, and therefore are contraindicated and not advisable. The RAAS blocker recommended as a standard medical therapy in patients with acute MI who are at high risk of future events, especially of heart failure, low EF, chronic kidney disease. And I showed you how the ACE nicely works in the attenuation of remodeling. And also I showed you from the European trial that the addition of RAAS blockade to standard medical therapy in patients with a previous MI of 65% who are not a high risk. They have normal function, well controlled, underwent revascularization. Still, we have a benefit of about 24% relative risk reduction and should be considered. And overall, ACE preferred unless there is intolerability or contraindication to use. And I do apologize for the few minutes beyond my time, and thank you very much for your attention.
Thank you very much, Dr. Musa. That was really very comprehensive, and we have enjoyed your talk.
Thank you.
And we did not feel that it was very long. Okay, so I think now I feel that I'm a bit, I won't say very confident, but at least I could use them for the right person, for the right time, in the right situations. So without further delay, I might start my presentations. Hopefully I won't take very long time. It is supposed to be a very concise chapter where we talk really about special population, and those are people with diabetes. So again, remember here, we're talking about things that we think it is our thought, and we want to check here these thoughts, whether it is a fact or a misbelief. So here I would ask you maybe in few times what things we are going through. So usually I would start with my disclosure. So I've been either advisor or a speaker for many of those pharmaceutical companies. So here we wanted to see in this special population with diabetes, does tight blood pressure control will have benefits in terms of their cardiovascular events? And then do we have an evidence to differentiate between the ACE and ARB in those diabetes with hypertension in regards to their cardiovascular morbidity and mortality, and then in their chronic kidney disease. So with this, I would start with this hypothetical cases where we have started. This is, I would say, a middle-aged man, 58 years old, known to have, he's not known to have coronary heart disease, but he's known to have diabetes for 4 years, taking metformin with hypertension, he's smoker and sedentary lifestyle. If you look at his medications, he's taking metoprolol for his hypertension plus metformin. Again, he's complaining of exertional dyspnea. So this is shortness of breath on walking. If you would look at his BMI, he's obese. Plus, he has got 90 beats per minute heart rate with a blood pressure of 140/38. Other than this, he did not show any of those, I would say, microvascular complications in terms of retinopathy. Now, when you look at his laboratories, here he has got his LDL, which is 4.4 millimole per liter. Here his fasting is 7.5 millimole per liter glucose, and HbA1c is 7.8%, while his serum creatinine is a bit high with the presence of microalbuminuria. Now, always in those patients, we wanted to ask, would you believe, this question is left for you. So do you believe that hypertension and obesity increase the risk of vascular complications of diabetes? So this is for you. So do you think this is true or false, or you don't know? So let's go over a few facts. Now, if you look at prevalence of diabetes worldwide, we are talking now about 500 million of people, adults who have got diabetes. Now, I just want you to see here in our region, which is the Middle East, North Africa, as well as others. Now, if you compare, we're talking about 40 million, but look at after 20 years, it's almost going to be double. Now, if you look at Africa, it's even more than double of this number in the coming 25 years. While if you look at Europe or others, you won't find that much increase. So it's usually 30 to 50% increase in the coming 25 years. So it tells you that we have got diabetes, and it is very prevalent. Again, if you look at different countries, you would look at the presence or prevalence of hypertension in those with type 2 diabetes. We are talking in average around 70 to 80% of adult populations having both diabetes and hypertension. Now, there are common risk factors between them, and this is always, we would say that they have got the gene, they are predisposed to have diabetes, hypertension. So this is an ethnic background. And then we would need a trigger. That trigger either is overweight or lipids or insulin resistance, where you would see all of those. You would see some dysfunction at the endothelial level or inflammatory markers, increase the fibrosis of the vasculatures, as well as arterial remodeling. All of this would lead to micro and macrovascular remodeling in the cardiovascular system, which would lead to cardiovascular disease. Now, we knew that people who has got diabetes, they have got very high chance for having other cardiovascular disease. So usually it is 2 times double of having this. Now, having cardiovascular disease and diabetes is almost 30% in populations. And we knew that the first killer in people with diabetes, it's always cardiovascular disease, especially if you talk about populations more than 60 years of age, we're talking about more than 50%. Now, different risk factors, if you would look at the death which is attributed, you would find here I might use the laser pointer in order to make it easier. So here, this is the raised blood pressure. So if you would see, according to this, the highest one is really raised blood pressure, then tobacco, then it comes uncontrolled diabetes, and then overweight and physical inactivity. So all of this are contributing to death, and the highest among them is really those uncontrolled hypertension. Now, having diabetes and hypertension is always reducing the life expectancy. So if you talk about men or women, both of them, they have got reduced cardiovascular, their life expectancy. If you have got diabetes, you would expect it that it would be reduced by 6 years. If you have got both vascular disease, cardiovascular disease, and diabetes, then you would expect 12 years life expectancy reduction. So having both of them is really not something that we would wish to have it. Now, this is a very nice survey which has been done in 2013, where they wanted to see at different levels at almost 2 decades, started since early 90 till 2010, and they wanted to see what would be the control rate on different risks, whether blood glucose, blood pressure, lipids, those who are using statins, and those three composite, the lipids, blood pressure, and diabetes. Now, if you would see here among different decades, you would find that we are not achieving much. Despite that, there was an increase in the control, but again, if you would look at controlling the three of them, it's always below the expectancy. So we are talking about 20% of people with diabetes whom they have got controlled blood pressure and lipids, as well as blood glucose. So this tells you that what you have been thinking is true, that both hypertension and obesity increase the risk of vascular complications of diabetes. Now, let's see another question, and we wanted to check on this. Does controlled blood pressure prevent cardiovascular morbidity and mortality in patients with diabetes? So what do you think? Yes or no, or you don't know? So once we control blood pressure, does it prevent the cardiovascular mortality and morbidity in those patients with diabetes? Let's see. Now, the UKBDS, it has shown that by reducing the A1C level, you're going to reduce different cardiovascular events, whether you're talking about micro or talking about macro vascular complication. So 1% reduction from 10 to 9 is always expected to be associated by 14 to 43% on different parameters, whether non-fatal or fatal stroke or MI, or those heart failure or amputations. Now, again, when you look at reducing in the UKBDS, the other arm where they have got a reduction in the systolic blood pressure, here you would see that there was significant reduction. If you manage to reduce the systolic blood pressure by 10 millimeter of mercury, so from 160 to 150 or 150 to 140, and this you're going to achieve almost 11 to 15% reduction either in the death or myocardial or microvascular complication. So all of this we knew it from the UKBDS, which we have seen. The good thing here always, if you want to see whether your intervention is really, I would say, cost effective, look at the number needed to treat. So now here, if you want to manage the blood pressure in those, if you would control it over 10 years, you would need to treat 9 to 23 people in order to prevent one of those events. So I think it's worth that if I'm going to manage patients with diabetes and controlling his hypertension for 10 years, I would need to manage 20 patients in order to prevent either one stroke or one myocardial infarction of these patients. This is an interesting where they looked at different trials of blood pressure control. And here, if you would see at different levels, whether they have been versus placebo or other competitors. And here they wanted to see those who has got in different trials managed to have a systolic blood pressure which is less than 140 millimeter of mercury. They have got a cardiovascular benefits, and those, if you would compare them between those who had been on placebo or this, you would see that the difference was sometimes as low as 3 millimeter and sometimes as high as 10 millimeter of mercury. So regardless of the reduction, you're going to have a cardiovascular benefit by controlling the systolic blood pressure. Now, so with this, we would believe that yes, by controlling the blood pressure in patients with diabetes, I'm going to prevent cardiovascular mortality and morbidity. So this is true. Now, this is our patient. So he went for echo, and with this echo, they found apical dysplasia. So it's not moving. There was apical hypokinesia, and he has got LVH, and that was seen. He has got reduced. He has got reduced ejection fraction by almost 43%. So this is his finding. Again, he went into butamine stress test, which showed that he has got a reduction in that one. Now, let's see how we could predict that patient might have cardiac events after having a normal butamine stress echo. So in those, the most predictor one is really diabetes, then followed by those who are failing to achieve their target heart rate. So instead of 120, they could not achieve more than 100 beats per minute, or others who has got hypertension and others. So all of them, it is a prediction for having a cardiac event in the first year. So if you did it, even if you did the butamine stress test, echo, and it was normal, again having diabetes, or others might predict that he could have it. So our patient, he had BCI on the bifurcations on left artery, and with that, he has been seen. So he has got the diagnosis of chronic coronary artery disease. He had the recent BCI at the bifurcations on the lab, and he has got hypertension, diabetes, dyslipidemia, and obesity. Now, we would go back to their managements at the end of this, but here, let's look at this and give me your feedback on this. So ACE would reduce the all-cause mortality, cardiovascular mortality, and major cardiovascular events in those patients with type 2 diabetes, while ARB has no benefit in these outcomes. So do you believe that ACE would reduce it while ARB would not have any benefits? What do you think? Is it true or false? Okay, let's see now. This is a hope study, so I'm not going in details of this, but again here, this is just to show you that in those patients with diabetes, they have got more than 3,000 patients out of the 9,000 patients, and with this, they wanted to see with ACE inhibitors, whether in that one it was ramipril, and they wanted to see whether they could have an evidence for cardiovascular disease or this. Now let's see over a period of the study, what happens to those who receive ramipril ACE inhibitors versus placebo. Here you would see that there was significant reduction in terms of their primary endpoint, which was the 3-point MACE, which was myocardial infarction, stroke, and cardiovascular death, and that was 25% relative risk reduction. Again, in the all-cause mortality, it has been 24% significant reduction, and again, for those who have got myocardial infarction, stroke, or cardiovascular death, all of them, they were significant by receiving ramipril or ACE inhibitors versus placebo in people of having diabetes. And this has been over 5 years period of follow-up. Now, the other trial is really advanced trial. And this one, again, it has got 2 arms. They have included patients who has got type 2 diabetes, more than 11,000 patients, And then they have randomized them, either they're going to receive the standard treatment or the other one, intensive glucose control. And the other arm for hypertension, they included the fixed combination of prindoprel, which is ACE inhibitors, and indapamide, which was the thiazide-like diuretics, versus placebo. The primary endpoint, again, they looked for the major micro or macrovascular complications. And here, this was the result which we have got after 5 years of follow-up, that a reduction of 5 millimeter of mercury versus 2 millimeter of mercury decrease. It has got a reduction in the cardiovascular risk by having the coronary, reducing the cardiovascular and coronary mortality. Again, it has shown that by lowering the blood pressure in those people, they have got a nephroprotection, and the full fixed dose combination of both the prindoprel and indapamide has got a reduction in their vascular events as well as in their death. So here, if you would see in the glucose arm, for those in the initial follow-up, which was 5 years, they have got the standard versus the placebo. Both of them here, you have seen that it was in favor of the intensive control, and the hazard ratio, it was 7%, but here it just touched the unity line, which lost their significance. But again, the trend is towards having an intensive blood glucose and blood pressure control. Again, when using both, and they looked at the blood pressure arm by using the prindoprel and indapamide, you would see that all-cause mortality, it has been reduced, and this was very significant, and it was like 14% if you would look at the hazard ratio. And with this, it was very significant for the favor of prindoprel and indapamide fixed dose combination. Again, when they looked at the cardiovascular mortality and all-cause mortality, here you would see it was very significant by 9%. And again, here it was very significant by almost 12%. So again, in both, it showed that it was very significant. This is a meta-analysis where they have looked into the ACE as well as ARB on the cardiovascular outcome in those patients with type 2 diabetes and they are hypertensive. So these are the studies which has been included, 13 studies, 5 studies of ACE inhibitors, while 8 studies of ARB, which have looked. So the endpoint, they looked into cardiovascular death, major cardiovascular events, MI, stroke, heart failure, and others after 18 months. So these are the studies which has been included in the meta-analysis, and this is just to show you for the ACE. If you would see all of them, they were randomized controlled trials. And here, if you would look at their p-value, you would find that it was very significant in terms of those patients where they have looked into cardiovascular death, myocardial infarction, stroke, heart failure, cardiovascular events. So all of them, we have seen that they have got a very well controlled and significant reduction in their terms of these events. Now, when you look at the ARB in this meta-analysis, again, you would find in all of them, it did not show a significant, because all of them, they have touched the unity line. So with this, we could not say. Not only this, even here, the cardiovascular death has been even increased with one of those trials. So the conclusion, ACE inhibitors has shown a significant cardiovascular protection for the 5 items: all-cause mortality, cardiovascular death, myocardial infarction, heart failure, and major adverse cardiovascular events. ARB had no benefits on these outcomes except for the MI. Now, in the view of differential benefits on the mortality and morbidity, ACE appears to be preferable to ARB in patients with hypertension and type 2 diabetes. So And this, you could say with a full confidence, yes, ACE inhibitors reduce all-cause mortality in patients with type 2 diabetes and hypertension, while ARB had no benefits on these outcomes. Now, what do you think? ARB are superior to ACE for prevention of CKD in people with diabetes and hypertension? What do you think? Or ACE inhibitors are superior? So is it ARB superior to this in terms of cardiovascular chronic kidney disease prevention, whether true or false? Let's see. Again, this is just to show you that from Cochrane database systemic review, they looked into people who has got diabetes as well as hypertension, and they wanted to see what would have in them. Now, again, they have included type 1 and type 2 diabetes, whom they have got normal albuminuria, and then they wanted to see what kind of outcome they would have, how many of them they would develop microalbuminuria or macroalbuminuria, death, or other which is related to chronic kidney disease. In the conclusion that ACE inhibitors were found to prevent the new onset of diabetic kidney disease and death in those who have got normal albumin, as well as there was no significant effect from ARB on the development of end-stage kidney disease or death. And from ARB, the only benefit seen in those who has got a very high risk for heart disease in this. There is a direct comparison between the ACE or ARB in this population showed no difference in preventing diabetic kidney disease. The benefit of ACE are consistent, and ACE could be the first choice intervention for primary prevention on diabetic kidney disease. This was from Cochrane database systemic review. So with this, we would say it's a false. ACE are superior in terms of prevention of chronic kidney disease. Now, the last fact that we wanted to check in those hypertensive patients with diabetes whom they have got moderate or high risk for this, they should be treated with RAAS and calcium channel blockers as well as diuretics. So which one do you think? So should we treat those hypertension, diabetes, whom they have got a very high risk with RAAS and calcium channel blockers or diuretics? So here from the European Society of Cardiology as well as the European Society of Hypertension on 2018, they have staged patients on different based on their blood pressure as well as presence of other risk factors, as well as they consider the hypertension mediated organ damage. So in those who has got an end stage disease, like for example, hypertrophy, cardiac hypertrophy or others. So in this, they would consider them whether stage 1 or stage 3, where they have got, I would say, CKD grade more than grade 4, plus diabetes and other organ damage. And this is very important because with this, you're going to have different targets of blood pressure based on those, whether they have got stage 1, 2, 3 on this. So those are very high risk according to their blood pressure, according to the score system, in which it has been a consensus between the European Society of Hypertension and Cardiology. And again, here they have got those with established disease, and they have got diabetes with target organ damage, or they have got severe kidney disease, or calculated 10-year score of more than 10%. Those are considered very high risk. High risk are those who have got very high single risk factor. For example, very high blood pressure uncontrolled, or very high LDL, where FH is there, or has got diabetes, but they do not have much risk factors like others. Those are considered to be high risk. Now, according to this, they have categorized them either according to age group and presence of other comorbidities. So here, if you talk about populations with diabetes, the target is almost systolic 130 or lower if tolerated, but not less than 120. Again, in those middle age, I would call them 65 to 80. the target should be between 130 and 40 if tolerated. For those geriatric more than 80 years of age, then the target should be again between 130 and 140 millimeter of mercury. And again, for the diastolic blood pressure, it should be between 70 and less than 80. So again, here they have put a different target according to the presence of different end organ damage they have got. Now, again, in those, they have got the strategies for those uncomplicated hypertension, but just remember that initial therapy in those is a dual combination of either ACE or ARB plus calcium channel blocker or diuretics. And in that, you should always consider dual combination. So the initial therapy should be a dual combination. You might consider monotherapy in those with the low risk grade 1 hypertension, or they are very old and frail patients. Now, in those who has got very high blood pressure and they are stage, in that one, you could consider adding triple combination. And in those, it has to be RAAS plus calcium channel blockers plus diuretics. In those step 3, where they are not yet controlled, in those you might add spironolactone or others if they have got resistant hypertension. You might consider beta blockers at any time if they have got specific indications for their use, especially if they've got heart failure, angina, or post-MI, or AF, or others whom they are having this. Now we would come back to our patient. So what advices we give him? To stop smoking, to lose some weight, to do some exercise, and in that low calorie and low carbohydrates and low fat diet. And then we have given him ACE inhibitors, prindopril 10 milligram, plus indapamide, thiazide-like diuretics, 1.5 milligram per day. And then we have added for him empagliflozin plus rosuvastatin, aspirin, and clopidogrel for him as antiplatelets as well as anticoagulant. So in those, he had received all the treatment for anti-ischemia and lipids, as well as controlling blood pressure with both ACE inhibitors and indapamide. Now, after 6 weeks of treatment, his A1C came down, his blood pressure is a better control, 130/78, while here LDL is 92 milligram per deciliter. And in that we have added ezetimibe because we are looking for less than 70, which came down. So now with this, yes, it is true. So in those patients who has got hypertension and diabetes, it's always advisable to start with a RAAS plus calcium channel blocker or diuretics as a dual therapy, and in which it has been mentioned many times. So here in patients with hypertension and type 2 diabetes, it's always inadequate control of blood pressure are always associated with cardiovascular risk. And we have seen it. Hypertension and obesity increase the risk of vascular complication. We have seen that ACE inhibitors reduce all-cause mortality, cardiovascular mortality, as well as major cardiovascular events in patients with diabetes, whereas ARB has no benefits on these outcomes. Now, the benefit of ACE are consistent, and ACE could be the first choice intervention for primary prevention of diabetic kidney disease. So in few of the differential benefits on mortality and morbidity, ACE inhibitors appear preferable to ARB in patients with hypertension and type 2 diabetes. So with this, really, I would like to thank you. Thank you for your active listening. And now I might call my colleagues, Dr. Musa and Prof. Claudio, to join us for the Q&A answer. So now we are going to listen to see your questions, your answers. I hope that it is not true, but I might start with this one, and I would leave the answer for both of you. Does ARB increase myocardial infarction? So we'd start with Prof. Claudio.
I have to start. Thank
Yeah.
you very much, my friend. I think that if you look at the trial, you can see that there is, in the most important trial, some trends toward a higher number of myocardial infarction in patients treated with RBs.
Mm-hmm.
This large meta-analysis I've shown that is clearly shown the opposite effect of ACE inhibitors and RBs on acute myocardial infarction. And the same is true, for example, if you look at the results of the LIFE trial or the On-Target trial, which are the two biggest trials in this field. In both cases, there is a small number, but there is always trend in the same direction of an increase in the rate of myocardial infarction in the RBs population. And in particular, the On-Target trial, it is in the comparison between ACE inhibitors and RBs. So I think that actually we can say, yes, probably there is less protection against coronary artery disease with RBs. And this, I think, is based on the mechanism of action of these drugs, on the huge increase in angiotensin 2 that you can observe when you treat your patient with these drugs.
Okay. Dr. Musa?
Well, with all respect to my colleague, Dr. Claudio, he mentioned about the two trials. The trial that I presented, the Valiant and the Optimal, they were recruited more than 14,700 patients. And when you compare them, it didn't show that there was an increase significant of MI. And also in Optimal, the Optimal also, they use 7,000. And those who have, again, post-MI, it didn't show a signal of increase of MI in these two. So there are trials showing, and there are trials didn't show. So in my point, and that with post-MI, these two trials, it didn't show a signal of increase of MI. Whether it really does increase, from these two trials, didn't show. So some of the trial it did show, but nevertheless, we use them in post-MI patient if they are intolerable to ACE inhibitors. So, my point of view that based on what I presented, it didn't show. Professor said, well, it showed in some of the trials. I think if it's really it didn't confirm as protective as ACE, but again, if the drug causes more of MI, then I think, the recommendation is not to use it, or still we are using. So I don't think that really a real increase, in my point of view, with all respect to my colleague.
Okay, all right. So in this, we could say that the studies which have looked into ARB did not show an increase in MI, but at least it was not protective, as we have seen in ACE inhibitors. Okay, now another question.
Yeah, question to me. I have seen the question in that, if you don't mind, Mr. Chairman, I'll read it instead. Please, more detail, how absent PCI patient is impact evidence of post-MI. In the SMILE trial, almost 2/3 have not received thrombolytics. Now, this is an old trial. This is not the standard care of therapy nowadays. This is a 1995 study. So at that time, maybe PCI wasn't the class 1 indication. It came just recent. It came under 2003, the meta-analysis and onward. So this is 1995. And that tell you that patient who's coming late or presented late, or they didn't have a time zone for benefit from thrombolytic with residual LV function, they benefit from the RAAS blockade. So that and the current practice, we do coronary angio for all patients, irrespective of reperfusion strategy is successful now. We do them nowadays. So our thought nowadays is totally different from 95. So that reflects the current practice at that time.
Okay.
But we
Now,
do PCI after even thrombolytics or not thrombolytics, so different mechanisms.
right.
I definitely agree. This is a very
Yeah.
good interpretation. I was one of the authors of the trial, so
Okay.
that was the practice at that time.
Yeah.
I think at that time the problem was try to see if the ACE inhibitor were able to protect the left ventricular function. That was the great topic.
Yeah.
After
And it did
yeah,
a good job.
and the
Yeah.
clinical practice has pretty much changed. And now, but now the guidelines are still saying that in patients with acute myocardial infarction, ACE inhibitors should be given to every patient unless there is a specific contraindication.
Yes.
So many steps have been done, but the trend have been always the same.
Okay. Now here, Professor Claudio, I've got a question. I'm a simple physician. I'm sitting in my clinic. Came to me, a gentleman without any other risk factors, with raised arterial blood pressure.
Mhm.
I did many times, and it is the same. Now, in these situations, should I start him on a dual therapy from day one, or should I start, I would say, uh, building it up, starting with one and then waiting for the other?
This is a very, very good question. It depends on, let's say, what you think about the mechanism of hypertension. I think that all the guidelines are following the same approach. The approach is that since we don't know exactly which one is the main mechanism raising blood pressure, we have a more possibility of reducing blood pressure by using multiple drug combination because we are targeting many different mechanisms in the same patient. And so I think I would prefer the combination treatment unless the patient has some specific contraindication. And even the European guidelines says that the monotherapy should be used only in frail patient aged over 80. And almost the same is true for the American guidelines. In the ISH guideline, there is one intermediate step, I think, which can be the solution of your question. You should start with a combination, but you're starting with the low dose combination, and then you should move to the full dose combination of drugs. But I think in terms of principle, since we don't know exactly which one is the mechanism supporting high blood pressure, I think that the best solution is to use a combination of drugs, at least in my opinion.
Okay. Now, I might just ask both of you very quick. Now, we have seen from these evidence that ARB and ACE inhibitors, no doubt, as a class, all of them are very effective and they are okay. Now, if I've given the choice to choose among them from those evidence, is it very clear that I should go for ACE, or when is the situations where I have to use ARB? So I would like to have from both of you your view.
But if I can start, now
Okay.
it's much better if Professor Akbar, because otherwise I'm monopolize the script.
No, no.
No, that's fine.
I have my idea, but I definitely prefer that Professor Akbar is giving his point of view.
Yeah, thank you. Well, it depends in which situation you are using. In post-MI with hypertension, I show you the evidence. Then the only problem with the ACE inhibitors is the side effects. Now, it depends, of course, it depends on which one you have comfortable to use. Some people, they still using the lisinopril, some people using quanapril, trinapril, or you're using the ramipril or perindopril. It depends on which one. But the most problem that we face with ACE inhibitors is the side effects. That does not mean that you don't use it. So use it. If the patient cannot tolerate, fair enough, then switch it to ARBs. Because remember, in all the guidelines, they said, read the guidelines carefully. ACE or ARBs. They didn't say the opposite. So use ACE or ARBs. So we'll go following the guideline, ACE or ARBs, following the clinical scenario that I showed you, LV dysfunction, heart failure, ACE is doing a good job. And then if cannot tolerate, then go to the ARBs.
Okay, yes.
Tolerability.
Actually, I think that Professor Akbar has a very wise position. And I think this is a good one. I've tried to study ACE inhibitors since the very beginning, and I do believe that the mechanism of blockade of angiotensin converting enzyme and increase in bradykinin can have some advantage. And so I do believe that that could be a good way to manage cardiovascular disease. But if the patient has some kind of side effects, and it cannot tolerate ACE inhibitors, I think that RBs could be a nice solution. But I would definitely prefer a double, let's say, a specific mechanism of action instead of just one.
Okay, excellent. So I think even if you talk to me as a diabetologist, if I have to choose, then it's always ACE inhibitors in those patients. If they are not yet tolerating, as you mentioned clearly, then I might go for ARB. So I think the question in most situations, ACE inhibitors are preferable based on scientific evidence. Unless patient is not tolerating, then ARB is another solution. Now, here just to ask, using, let's say, RAAS plus other drug, in that situations, the second drug or the other drug in combination with RAAS, which one would you prefer, calcium channel blocker or diuretics or very specific thiazide-like diuretics?
Actually, I think we have to follow the trials. We have all these combinations are very effective in reducing blood pressure. So in my presentation, I try to see which one are the evidence that are addressing one combination in comparison to the other one. Actually, I think in the average hypertensive patient, high-risk hypertensive patient, maybe the combination of ACE inhibitors and the calcium channel blocker would be the best. I do believe that the calcium channels are very important in the target organ damage and in the blood pressure control, and they are pretty much neutral from the metabolic point of view. So they are interacting very well with drug inhibiting the renin-angiotensin system. But you know very well, because it's your topic, that in the diabetic population, the combination of ACE inhibitors and diuretics is working very well. But in this case, I think we have to try to focus on thiazide-like, and in particular on indapamide, because indapamide is a peculiar diuretic. He has also some diuretic effect. But if you look at the pharmacological profile, indapamide is more closer to a calcium channel blocker. So that's the reason why I think it could be so effective in the many trials in which has been used, and is actually the only one, along with clothalidone, who has a a single drug trial in which has a positive outcome. It doesn't happen with the hydrochlorothiazide.
Okay. Now, again, Dr. Musa, now
Yes.
your population where you have got a patient in CCU and they have got an acute Cohen syndrome, in that situation, is it the right time to start them on RAAS or ACE inhibitors, or you would wait, or based on blood pressure?
In patient, we are seeing a different heterogeneous group of MI. There are inferior wall MI, very stable with high blood pressure. There are anterior wall MI who have blood pressure on the low. We do echo on all of them, and they have depressed LV function. They have preserved LV function. So we take the clinical pictures of the patient and we decide upon. But if the patient's profile in the coronary care unit within 24, remember the data here, within 24 hours. It didn't say exactly when he will admit it, give him the ACE inhibitors at the 0 time. It's within 24 hours. So that within 24 hours, we will assess the patient's clinical condition, Kileb class, LV dysfunction, what is the blood pressure, MI, previous MI. We put all this together and we see the blood pressure, and then if we feel safe in giving them, we will initiate it as early as possible, because we believe in the two trials that I have shown you, the ISIS 3 and the GC4 showed that within 24 hours, you have mortality reduction. So we give it early if the condition allows giving the things that I told you, the echo, the blood pressure, and where the MI is occurred. Is it anterior, inferior, lateral? So we take all of this together and then we initiate it within 24 hours. Yes, we do it.
Absolutely.
Here, I've just final question. I just wanted to know, do you think the effect of ACE inhibitors is related to the reduction of the blood pressure, or is it something that I would say maybe related to the mechanism of action? For example, when we talk about diabetes, we have got different. They might not respond by reducing the blood pressure, but still the benefit is there. Now, do you think what we have seen from the ACE inhibitors is related to the reduction in the blood pressure, or is it something where we would believe it is because of the mechanism of action of the class?
Actually, I think that most of the benefit is due to the blood pressure reduction, but this is not the problem of ACE inhibitors. Every antihypertensive drugs reduces the rate of cardiovascular complication primarily because it reduces blood pressure. There is no protective effect beyond the blood pressure control, at least in hypertensive patients. So first of all, we have to reduce blood pressure. And after that, you can have some additional effects, which are specifically effect of the drugs or the combination of drug. I think the most clear evidence is the one coming from the ASCOT trial. On both sides, we have a combination of antihypertensive drugs. They are reducing blood pressure to the same extent, but the benefit is for ACE inhibitors and the calcium channel blockers. So actually, whenever you have reduced blood pressure, you're going to have an extra benefit, which is due to the mechanism of action. And I do believe that ACE inhibition, renin-angiotensin system blockade, and calcium channel blockade is the more, let's say, available, the more reasonable for the control of complication in hypertensive patients.
Dr. Musa, do you have any?
Yeah, of course. We, we believe also it's beyond blood pressure control, and we have seen it on the mechanism why we have a mortality reduction in those trials that I presented for you. None of all of this showed that a blood pressure reduction was the major responsible for the outcome that I showed you, and therefore the attenuation of the remodeling, the preconditioning, the sudden death, also the recurrent MI, the philosophy behind why ACE inhibitor reduces a recurrent MI. One of the thought that theoretically the ACE inhibitor through the bradykinin system and nitric oxide and improving the endothelial function, it restores the oxygen demand supply. And that one of the major that they will have less recurrent MI or less future recurrent MI. The other theory that they believe when you have infarction and ischemia around the infarcted area, the ACE in that tissue is very high. And these ACE are having more deleterious effects, and the blocking ACE in this tissue has a beneficial effect. In addition, that the nitric oxide and the presence of local TPA produces also the inhibition of the PI, the antithrombotics, so all these beyond the blood pressure. So the benefit, yes, it's beyond blood pressure control.
I think that one of the examples that we can have effect beyond the blood pressure is this effect of ACE inhibitors and RBs in the COVID-19 patients.
Yeah.
Because in that patient, there is no, of course, some of them are hypertensive, but they are usually not hypertensive during the acute phase or during the disease. But anyway, they can have some benefit because of the interaction with angiotensin too. So, but this is not the case of hypertensive patient. In hypertensive patient, you have first of all reduced blood pressure, and then you have to take care of which one is the mechanism for the blood pressure reduction. And so I think what Professor Akbar said is absolutely important.
Okay, excellent. Now I've got a question which really seems to be a very interesting, and this is a mother, 67 years old, having hypertension, diabetes, taking losartan and metformin. Based on my understanding from this presentation, ACE inhibitor is more significant reducing cardiovascular disease than ARB. Now the question, is it possible to shift from ARB to ACE inhibitors? And if yes, how?
How? Why?
Okay, we would assume that she's controlled, let's say. Okay.
I think that if everything is well controlled, actually, I don't think any reason to force the treatment in these patients. Because of course, I do believe that ACE inhibitors are a very powerful drug, but I think that if the drug is working, if there is no interaction with the other drugs, the blood pressure is well controlled, I think she can get some protection from RBs. We don't have to change every patient to switch every patient from one to the other one if the situation is stable. We still have a lot of problems in stabilizing the patient, in achieving the good blood pressure control. If we are going to change the treatment in those who are already controlled, I think is a vicious circle.
Okay. How about you, Dr. Musa?
See, I agree with the professor that what he said. If the patient is happy, blood pressure control, and you remember one thing, it's there is no superiority of drugs in terms of, very compare that there is a superior in more mortality reduction as a comparable. I'll give you one example. In usage of ARNI versus ACE inhibitor, in the Paradigm trial, they compare these two drugs, and it showed that there is superiority of combining with ARNI in terms of 20% composite endpoint, mortality reduction, sudden death 16%, hospitalization of heart failure. Then the recommendation, if the patient in an ACE, replace it with ARNI because of these data. Now, the situation is different in this situation. So we, as a professor said, patients comfortable with the drug, he is tolerating, blood pressure to the target, don't touch it, please, leave him on the drug.
Okay.
And then the scenario of the case is doing very well, don't play with medication when the patient's very happy, because if you put him on ACE and he develop cough, you will regret for that. So just keep him, make the patient happy.
But the problem of cough is important, but is even more important that we don't know at which stage of cardiovascular risks are the patient. You are going to change an effective treatment, and your patient the day after is doing some complication because of his natural history, not because of the drugs. And everybody would say that this happened because you have changed an effective treatment. So I don't think it's a good policy.
Okay, so it's so the message is always, as we have mentioned, ACE inhibitor has got significant superiority in reducing the cardiovascular disease and outcome compared to ARB. But if your patient is taking ARB and they are very well controlled, don't change anything, don't replace them, keep them as long as their blood pressure is well controlled and they have no other problem. So I think really we have enjoyed it, and I'm very happy to tell you that up to now we are getting more than 400 attendees are still with us. So it tells you that really it was very much interesting. Now, before closing, I just want to have a reminder for attendees and colleagues that this webinar and this program is accredited by Saudi Commission for Health Specialties by CME. So please register, and you're going to receive it within 2 weeks from here. And now with this, really, I don't want to close, but I have to we have to do something else. So thank you very much, Professor Claudio, Dr. Musa,
Thank you.
for survey. Special thanks for Dr. Fuad Radwan, who had been working on the last 1 month on this. And I think we have enjoyed it. This was, I would say, renin angiotensin aldosterone system checking program where we are checking facts. We have seen few things where we believe that with the evidence we have shown you that where do we stand, and that RAAS has got a very important role to play either in hypertension or in patients with acute MI or diabetes. So I think with this, I would like really to thank, very special thanks for Professor Claudio Bosch, who has been with us from Italy, and again for Professor Musa Akbar, an interventional cardiologist who had been with us from Kuwait, and a special thanks and regards from me to all of you. Thank you very much, and I hope to see you very soon.